Thank you, Michelle. I'm delighted to be here. I'm going to talk today about preference-sensitive decisions, and I'll define that, and shared decision-making and clinical guidelines. So for the past 15 to 20 years, a fair amount of my work has been in clinical guidelines, and I'll tell you a little bit about that. Before I get to that, though, I want to talk a little bit about my affiliation. So every quarter, the provost gives a briefing for the chairs, and for the first one I went to, I picked up my name tag, and lo and behold, here is my name tag saying that I'm the chair of the Department of Otolaryngology. Now, Tina thought she was. I was very excited about this, and I showed it to Linda Boxer, and she said, well, Doug, you just got a very big raise. I'm like, don't rub it in. But I am thrilled to be here in my actual home department, and my first act as chair will be to move your grand rounds to noon. All right, so I have no financial disclosures. I was on the U.S. Preventive Services Task Force that I'll tell you about for a number of years and served as vice chair and chair. So what I'm going to talk about is in guideline development, how do we make recommendations that promote the outcomes that patients value? That's the goal when you're trying to make a set of recommendations. And how do you go about that? And I'll tell you a little bit about how in some circumstances the U.S. Preventive Services Task Force does that, and I'll explain what it is because you may not be familiar with it. So the task force is 16 people, and they make clinical recommendations about clinical preventive services in 3 areas: screening, tests, counseling, preventive medications. So these are aimed for primary care providers, and the task force has 80 to 90 recommendations, and almost every primary care provider uses some of them, I would say. The task force grades these recommendations that they make in this ABCDI system. A and B are recommendations to do something. And right now, the Affordable Care Act says that if the task force recommends something as A or B, it must be paid for without copay. The C is do it sometimes, and I'm going to kind of talk a little bit more about that, where the average net benefit is sort of small and maybe not be the same for everybody. D is usually don't do it, and I is when the evidence is insufficient. So I'm going to give you 2 examples from the task force where essentially it was called, the recommendation called for shared decision. You probably know that breast cancer screening in women 40 to 49 has been controversial for years. Different recommendations from different groups. And this was the 2016 wording for this age group from the task force. The decision to start screening mammography in women prior to 50 should be an individual one. Women who place a higher value on the potential benefits than the potential harms may choose to begin biennial screening between the ages of 40 to 49. And that was a C recommendation. So this was essentially a recommendation to do shared decision-making with women in that age group. The second example, and that guideline just changed, they now recommend that for women in their 40s. The second example is prostate cancer screening. As you also may know, it's a long-term, potentially controversial recommendation with different people coming to different recommendations. I'm going to show you the actual text. I'm not going to go through it, but so for men age 55 to 69 years old, the decision to undergo PSA screening should be an individual one. I'm going to get to how we go about this. Before deciding whether to be screened, men should have an opportunity to discuss the potential benefits and harms and incorporate their values and preferences into the decision. This next blurb, which is directly from the recommendation, talks about the benefits and harms and tries to lay those out, what you would want to discuss. And then the recommendation concludes by saying, in determining whether this service is appropriate in an individual cases, patients and clinicians should consider the balance of benefits and harms based on family history, race, ethnicity, comorbid conditions, and patient values about the benefits and harms of screening. So what do we mean by that when we say how the patient values benefits and harms? So when I say something is a preference-sensitive decision, what I mean by that is it's a choice in which how patients value the health outcomes will change the preferred option. So let's take an example, low back pain, okay? And let's say you have low back pain that is worse when you stand, and the longer you stand, the worse it gets. As an internist, I can do most of my work sitting at a computer, certainly now, and that wouldn't be such a big deal. But if you're a surgeon, for example, and you have to stand for hours at a time, that might be an incredibly big deal. And so how we value the same functional state differs between people. So for those reasons, patients' evaluations of health outcomes are highly variable. I'll show you an example. And it turns out we're not really very good surrogates. If you ask patients how they value something, you ask the clinicians, often doesn't agree. This is just an example from a long time ago that we did asking people about the quality of life with stroke. And it's a sample of 70 patients. And when I say patients' utilities, what I mean is that it's a formal term, but I mean how patients rate the quality of life with stroke using a particular instrument. And at the top panel, you see the utility for mild stroke, moderate strokes in the middle, and utility for major stroke is at the bottom. And if you notice, so the y-axis is just the percent of patients, it's just a histogram. And quality of life in these instruments that we use are usually rated from 0 to 1, 1 being perfect health over on the right, 0 being death. And actually, in this case, we allowed people to say something was worse than death. And if you go from the top to the bottom, you see that the patient's ratings of the quality of life move to the left. They move to worse, which you would expect. You're going from mild stroke to moderate stroke to severe or major stroke. But the main point I want to make here is look at the range. There is tremendous variability. And across many, many, many conditions, when this is studied, that's what you see, this high variability, because patients just think about these outcomes, they value them differently. So when do we think about using shared decision-making and guidelines, at least for the task force, I would say is typically when we think there's a close correlation. The benefits and harms are pretty closely matched. And the preferred option really depends on how patients value those things. Are you more worried about the false positives, et cetera, or do you really focus on the mortality benefit, and is that more important to you? So these are often C recommendations where on average the benefit is small, but it might vary between people depending on how they value these different outcomes. So that's sort of how the task force did it. So I would say that in guidelines, shared decision-making can provide a pathway to inform patients about the pros and cons of the intervention. We believe, at least when done well, you have the opportunity to promote the decisions that lead to outcomes patients most care about and most want. It is, of course, hard to implement. We're going to hear about tools, et cetera, later in the talk. In time-constrained settings in clinical practice. So it's not a very popular thing to suggest, but we do think it has a role and can be important. Thanks very much.
Thank you, Dr. Owens. So next we have Dr. Sonia Bonifacio from the Department of Pediatrics.
Good morning, everybody. Just set my timer here. I don't go over. I'm Sonia Bonifacio. I'm a clinical professor in pediatrics in the Division of Neonatology. And thank you so much, Doug, for setting up all the keywords about values and decision-making and guidelines. The complicated thing in neonatology, of course, is that our patients can't talk to us, right? And so we're thinking about the values and the preference of the families that they're going to go home to be cared for by. So we're going to talk about shared decision-making for the need for chronic ventilation. And we're just going to review diagnoses that lead to the need for chronic ventilation in the neonatal population, discuss approaches to shared decision-making between families and medical teams in this very sick patient population in which they themselves don't have a voice, and to highlight the importance of identifying gaps in support for families during and after tracheostomy. So just to set us up, this is a current patient we have in our unit right now. This was a preterm twin who was born at 34 weeks gestation with a giant omphalocele. And for those of you who don't know what that is, basically their entire liver, a lot of their intestines are encapsulated in a sac outside of their body. This baby has chronic respiratory failure due to abnormal lung development and abnormal mechanics. You can see their chest x-ray just after birth. They have a very long thorax. Was still vent dependent at 4 months of age and is now 7 months old in status post-trach and G-tube. He's required high vent settings, has had multiple episodes of infection, significant pulmonary hypertension, and chronic exposure to sedating medications. And he's still hospitalized even after receiving his trach. We're now anticipating that he's going to be spending at least his first full year of life in the hospital. And even after that, it's very difficult for us in the NICU to transition patients to at least getting them home because we have a lack of nursing support in the area. And there are very, very few, actually only one long-term care facility in the immediate vicinity. So with resuscitation of more extremely preterm infants, another thing you might not know is that we now resuscitate babies who are born at 22 weeks, so about half of a gestation. We see increasing numbers of babies with severe bronchopulmonary dysplasia and need for chronic ventilation. About 2 to 4% of preterm infants with BPD will undergo tracheostomy overall, and about 1/3 of those with severe BPD will need a trach. Additional etiologies for us in the NICU include subglottic or tracheal stenosis after prolonged ventilation, or babies like the one I shared with you who has a giant omphalocele. And there are currently no evidence-based criteria or consensus guidelines in tracheostomy placement in this population. So just to remind you what we're dealing with, we are dealing with babies who are born at about half the gestation they're supposed to be at, and their lung development is quite premature and kind of arrests at the stage that they're born at. So for those 22 weekers, they're being born between the canalicular and the saccular stage. And then not only is it an arrest of development that happens after birth, but then there's chronic insults after that with prolonged ventilation. In general, our goal in neonatology is for patients to survive and thrive, but we have to recognize that the things that we do to sustain life can come at the expense and without a clear focus on how we as providers safeguard the potential for each child to develop into, or each infant to develop into a healthy child. And so we have lots of examples of shared decision-making in neonatology. If we're just thinking about the preterm infant, we have to think about shared decision-making in whether or not we decide to resuscitate a 22-week infant. We also have opportunities kind of along the way to make sure that we're doing shared decision-making about redirection of care after a severe brain hemorrhage, severe necrotizing enterocolitis that might leave a child without any functional intestines, in the settings of sepsis with a subsequent neurologic injury, and then trach for chronic ventilation. So this is just a general framework for shared decision-making in the NICU, and it does really bring into some of what Doug mentioned in terms about thinking of the values of the patient, and in this case, the values of the parent and the family. And then what we do as physicians, we have to try to put aside our bias that we have here on the right-hand side of the screen and think about the parent's emotional state, their psychosocial factors and anxiety, take their values, and then think about asking them specifically about hope, quality of life, spirituality, and then personalizing the decisions that we make together. I really love this framework, and I hope that you will potentially adopt this as you talk with families in the NICU. This was a framework created by Monica Lemon at Duke. It was created about giving bad news in the NICU about neurologic outcome. And I think it works for a lot of things in the NICU because much of what we do, whether we realize it or not, does have a potential impact on neurodevelopmental outcomes for patients. And so in this framework, there's the approach. When you sit down with the family, you want to elicit, first of all, how they want to be communicated with and what their baseline understanding is of the situation. And then they really want us, this came from parents, actually, this framework was created between physicians and parents. Parents want us to be transparent. They don't want us to hide facts. They want us to provide balanced information, and they want to discuss kind of the effect of the things that we're doing on day-to-day life. And then we can follow with giving support and then planning our next steps. So it's a really helpful framework for all types of conversations in the NICU. There's not a lot talked about in the literature about outcome-centered counseling around tracheostomy, but this is one paper that, again, involved parents in this research project. And these were the questions that came out for families. Will my child survive? When will my child no longer require trach? Will my child experience developmental delays? What's the best timing for a trach? None of us really seems to know the answer to that. And there's not a lot of research about that in terms of if you do it earlier, is that better for the lungs? Is that better for neurodevelopment? Or is waiting later and giving the child a longer chance, although having to stay in the hospital to maybe not need to have a tracheostomy, is that better for them? And then they always want to know, when will my child be able to go home? We also have literature to help us understand what parents need to help them with their decision making and being a partner with us as care providers. And I've highlighted a few of these things that came up frequently in interviews with parents. They really care about and are influenced by the interactions that they have with the staff and the medical team. They really want to have a trustworthy relationship with the team. They need consistency in care and caring staff, and most importantly, they need consistency in messaging. And this is something that we struggle with in the NICU a lot because there are a lot of different teams that come to help us take care of a patient. And so making sure that the otolaryngology team is saying the same things that the NICU team or the surgical team or the quality of life team or now palliative care team is saying is really helpful for a family, and nothing derails them more, especially after they spend 4, 5, 6, 7 months with us when we are saying different things. It makes it incredibly complicated to care for them. Finally, I just wanted to raise this because I think it's something that needs to be talked about every single time we talk about a trach and do other things in the NICU, is whether or not there are disparities and do disparities impact access and support for chronic ventilation? And I think for sure in our area, they do. Finally, I think this is a complicated thing that we do for our families, to really centering our care on the patient, which for us as neonatologists is not just the patient themselves that we're doing things for, but their entire family, and then taking care of each other as a team really helps us to make sure that we're doing the right thing. So in conclusion, the limits of viability have been pushed to 22 weeks gestation, which leads to more babies with more severe BPD. Those children have a significant risk of needing long-term chronic ventilation, and we need to do shared decision-making in order to make sure that we, first of all, put the baby and their family in the center of what we need in order to approach this, making such complex decisions for them that can have lifelong consequences. So thank you.
Thank you. So next we have Dr. Kavita Ramchandran. She is a professor in the Department of Medicine and in the Division of Medical Oncology. So it's great to come in after our lovely folks in pediatrics and policy. So I actually had a case to share, and it's a real case. And I present this as an opportunity for us to think about how we think about things as physicians. And then I have a question for all of you, and maybe we'll wait to the end to ask the question because it might lead to some discussion, and maybe that's the right place for the discussion. So this is a 58-year-old male with a history of essential hypertension, a periapical abscess, presenting with sinus maxillary cancer, and coagulopathy. This is coming directly from notes. The patient was relatively healthy until December of 2022 when he noticed swelling to his left cheek. He initially attributed the swelling to a dental infection and had a left maxillary tooth extracted around that time. However, the swelling progressively became worse and painful. So in March of 2023, he was diagnosed with an invasive squamous cell carcinoma after diagnosis from a left maxillary mass biopsy. He had a CT neck with contrast with a large mass arising from the left maxillary sinus with destructive changes in the medial wall, posterolateral wall, orbital floor, left maxillary alveolus, and left pterygoid plates, with local invasion to the left masseter and pterygoid muscles, local invasion to the left ethmoid air cells. He had lymphadenopathy in the left submandibular and submental region, lymphadenopathy in the left suprahyoid posterior cervical triangle, and then also had a dentigerous cyst containing a molar tooth in the inferior aspect of the right maxillary sinus. On April 28, 2023, the patient consulted with oncology and head and neck surgery for a left nasal cavity squamous cell cancer. He had a plan for a PET CT and an MRI with a discussion to possibly do induction chemotherapy. He had referrals made to MedOnc, RadOnc, dental, palliative care for pain management since at the time. And then in May of 2023, he was consulted with medical oncology, where they discussed that surgery had not been recommended as first-line treatment, given the large extent of the resection that would be necessary and to avoid potential loss of his eye. Discussed that combination radiation and chemotherapy Q3 weeks was an effective treatment strategy that was intended to be curative. Also talked about alternatives such as cetuximab, taxanes, as well as others, with a plan to begin radiation after initiating chemotherapy, and would assess the role for surgery, if at all, after chemo-RT. Okay, so I will ask this question. First of all, I stumbled over my words, and I'm a medical oncologist, and I went through the notes for this patient, and I actually asked someone to help me to distill what was important in the notes and to copy and paste what they thought was important into a couple of slides. That's what they copied and pasted, and then I was like, I feel like I'm missing something. So I went back to try to find all the things I was missing, and I couldn't find very much. So I wanted to ask, after reading that really thoughtful chart with an enormous amount of detail, especially with Dr. Owen's very thoughtful introduction about values for the patient and shared decision-making, especially since I can guarantee you, this is not an NCCN Category 1. So when we think about our US Preventative Task Force guidelines, we have an equivalent one called the NCCN to say if it's a Category 1, it's pretty much, we should do it this way. But many things that we do in the NCCN guidelines are Category 2, 3, 4, where it is about bringing patient's values in, doctors' decisions in. So I'd love to hear what you heard about the patient's goals and values in those first couple of slides. Nothing, right? Can I ask the non-head and neck surgeons what they understood? There's a lot of physicians in this room that are not head and neck surgeons. What did they understand about this situation and the risks, the benefits, and the medical pieces?
Surgery was going to be extensive.
Yes.
So probably wasn't the best option because there were other things at risk.
Perfect. Anything else that folks understood?
A lot of potential for mixed messages, and I'm concerned about the patient's reaction to all of this from a mental health perspective.
Yeah, absolutely. So lots of other, questions from the physicians as well. Other things that people understood from this first couple of slides? Have you guys been here before? Yeah, I see some heads nodding. Yes. How does it feel? I heard the head nodding back there.
I had this again patient a couple of months ago in the ER. He didn't understand that his choice was to try to save the eye.
Right.
He just got put into that scenario where he's going to try this neoadjuvant induction therapy, and he was at an outside facility, and they said, "Oh, you need to go get surgery." And then he showed up here, and we again tried to explain that he should pick his path because he was trying to save his eye, but the patient had no idea that this was a decision about trying to save his eye, not save his eye. And when that was explained to him, he was, understood why he wasn't getting surgery right away. But it is very confusing for our patients.
Yeah, so you hit on something really important, which is the patient has to understand what are the trade-offs, right? So how do they know what decision to make if they don't understand the trade-offs? Going back to the stroke question, really, we don't know. If you don't know the trade-offs, you don't know what decision to make as a patient. Other thoughts that folks have? So I will say that this is how this patient felt. He was despondent, in despair. He had no idea what to do. He had spiritual and existential angst. He had a job where he was the primary breadwinner in his family. He was caring for a parent who needed help. He had a wife who was working 2 jobs. And he had now met I would like to say about 20 people. I don't know how many people you saw in those first 4 slides. Between all the main people and then about all the other residents, and interns, and nurses, he met about 20 people. He had no idea what to do. And not only did he have no idea what to do, he was in utter distress. He was in so much pain, he did not know how to handle the pain. He felt like his eye and his face was going to explode. So if you think about trying to get this complexity to a patient who has a face that's about to explode, which is what you guys are dealing with on an ongoing basis, that's how this gentleman felt. And so I bring to you what I hope would be a slightly different paradigm, which is, so I'm a medical oncologist and a palliative care specialist, but we have these amazing folks in the room here today. And I wonder if there's an opportunity here for us to think about shared decision-making differently. I actually think, and I don't know if other people, Heather, I'm curious, you've worked at other institutions, whether folks do work together instead of separately.
I would say it's more separately than together.
Yeah.
Maybe some discussions in group formats, but not.
Absolutely. So these are some of the core folks, and Heather, I should have included therapy because that's actually one of the critical pieces. But I think what we really need to do as a team is we have a burden on us that we're not actually, and a responsibility. I think you might do it better in pediatrics than we do in adult, to do work together better and to communicate a little bit more clearly. I also think that we have a responsibility in our charts, and I look at our residents who are learning to think about like the values of the patient and family, to think about how to insert them into our chart a little bit better, to think about who they are, in terms of their identity, who they are socially, what are their needs from a financial standpoint, what are their trade-offs down the line in terms of what they're willing to hold or bear. As we said, we have physician bias put in, and try to put that into the chart, like actually start to put it into how we speak to folks, put it into our records, start to include it in our conversations, so that when we come in to see a patient, we see them as that person, not just all the pieces that we're putting together as physicians, because these are complex situations. So that's probably my main call to action. And in terms of our own setup, I think we also have to recognize that we're in an area of uncertainty, that we don't always know what to do, and we're not always doing it with all the best evidence. And so for us to also speak with the sense of humility in that we're doing our best, I think goes a long way. There was a great article that was actually published out of the Netherlands a couple of years ago about decisional conflict. If you can get head and neck cancer patients to a point where they feel good about the decision that's being made, even if it's a hard decision, they're much less likely to have long-term poor outcomes. But in terms of their emotional state and their depression and their anxiety. But if you cannot get them to a point where they have feel like they've made a good decision, then they're more likely to have trouble with that long term. So I think that concept of decisional conflict and really helping patients get to that place is important. So, yeah. All right. The AFib guy. All right, next we have Dr. Randall Stafford. He is a professor in the Department of Medicine, as well as director of the program on prevention outcomes and practices.
It's really great to be here today, and faced with this conundrum of how to use 8 minutes to talk about something that I could talk about for hours on end, and how to make this relevant to the folks in the room. I'm going to take a very practical viewpoint and sort of say, okay, let's think about decision making. Let's think about this idea that there are going to be decisions where there is some level of equipoise, where the patient really needs to weigh in on what their values are, how they gauge the severity of certain outcomes, whether they be positive outcomes or negative outcomes. And how do we actually dig in to make this happen? So I want to present very briefly an example of decision making that we've implemented. Unfortunately, it takes a little bit of setup to kind of talk about it. So I'm going to leave out some important details, but I hope you get the idea. So as part of an American Heart Association grant, a group including Paul Wong in cardiology, we developed a decision-making tool that essentially would expose patients to information regarding atrial fibrillation and the value of anticoagulation for stroke prevention. And this is a topic that, while it might seem obvious, in some ways, if you dig into this topic, is far from obvious. You know, we know from national data that the number of patients with AFib who actually get anticoagulated is far from 100. It really ranges in the 60 to 70% range. It also is a decision where there are huge disparities by socioeconomic status and by race ethnicity. It's also a topic where, in many ways, the medical care system has substituted its judgment for what people might value on their own. And this is kind of part of what I think of as an inherent bias in medicine towards a certain type of paternalism, where the doctor, with the information, with all the details, is much better poised to make a good decision than patients could ever make. So our goal here is really to set the patient up for a critical decision-making visit with a clinician. And in this case, we are thinking that the clinician could either be a primary care physician who's basically going to be reviewing the value and the downsides of blood thinners for atrial fibrillation, or could be a specialist, including someone as subspecialist as an arrhythmia physician. So I want to take you through this just to show you some of the issues that kind of come up when we start to think about how do we actually implement decision making. So again, the goal here is really to expose the patient to the information they will need to have a shared decision-making discussion with an expert, whether that be primary care or a cardiologist. So first of all, one thing you can see is that this is actually both in English as well as Spanish. You know, we have a population in most parts of the United States that is not homogeneous, and we need to take into account the different language preferences of our patients. So we begin this by essentially setting up this idea that the patient is stepping down a particular pathway towards a decision. And again, all of this is meant to precede a visit with an expert and make the decision. So this is a kind of decision-making tool that precedes the actual work of the clinician. So what we have here is basically a way of presenting key messages and then reinforcing those messages. Also trying to cater to patients who may have different desires for details. Some people can go through this in 10 minutes. Other people can play around with some of the aspects of this, for as long as a half hour or 40 minutes. So we start out with a video, and I'm not sure the sound is going to work here.
Doctors are there to help you. You are the expert in your life and your health. This tool can help you decide if you want to take medicine to reduce your risk of stroke due to atrial fibrillation. Normally, the heart beats regularly, pumping blood to the rest of the body. So, what is atrial fibrillation? Atrial fibrillation, called AFib for short, is when the upper chambers of the heart beat very rapidly and irregularly. Some people feel a fluttering in their chest. Some people don't feel well. Many people feel nothing at all. Blood is usually moving through your heart. When AFib happens, some of the blood doesn't move. When blood doesn't move normally, it can form a solid clump called a clot. If the clot breaks off and is carried away in the bloodstream, it can block the flow of blood to your brain. Without blood, the blocked part of the brain will start to die. This is a stroke. A stroke caused by a clot can happen anytime, any place. If you have a stroke, you may die from it. Or it can lead.
I'm going to skip ahead to the very end. Essentially, what we're doing here is going through, well, what is it that blood thinners are meant to prevent? And then there's a similar section going through, well, what are some of the adverse effects that can be caused by blood thinners? But I just want to skip to the end.
And work together to help you make this decision. And you can always change your mind later. You can think of your decision as two paths. On path one, you could say no to blood thinners. I have a higher risk of bleeding because of other health problems. I decided to live with the risk of having a stroke. On path two, you could say yes to blood thinners. I can't risk having a stroke and losing my independence. Before choosing a path, people like you have found it useful to learn more about the benefits and risks of each choice. Talk to your doctor and use this tool so you can make a choice that you are happy with.
So this whole video is really meant to kind of orient people, to give them main messages. And if we think about what the messaging is, the first message is really that you as a patient should have a role in this decision. And I think it's really important to kind of put that out there as the foundation for shared decision making. Not all patients are going to accept that. Not all physicians are necessarily going to accept that. But that is the premise of the shared decision making process. I think the other two messages that are kind of obvious are what's the benefit and what are the potential harms. And then the fourth message is really one about the need for the patient to weigh in and balance what they feel about these two outcomes, and to be in a position to really take ownership of the decision that they're making. The tool goes through some common questions. Here are two of them about how do I compare the risk of bleeding and risk of stroke, and is there a way to reverse the effect of blood thinners? We then have what essentially is a little bit of a quiz that again takes these main messages and puts them out to patients in a very kind of low-key way, so that if they do get the wrong answer, they're really directed.
AFib is a
back
common
to
heart
the
condition.
proper decision or the proper.
When AFib is untreated, it can lead
And
to
then
stroke.
finally, skipping ahead here, we generate a worksheet for the patient that basically enumerates what their key issues are that they're taking with them into the patient office and part of that conversation. So I'm going to leave it at that. I think this is like such a brief introduction to this topic, but I'd be glad to delve into some of the issues that I think this, the design of this tool takes into account, and why those are such important issues. Thanks very much.
All right, next we have Dr. David Magnus. He's the Thomas A. Raffin Professor of Medicine and Biomedical Ethics, as well as the Associate Dean of Research.
Okay, thanks very much. I'll try to go quickly through a huge amount of ideas and material, so we'll try and get through this as quickly as possible. No conflicts of interest to disclose. So first, just a real brief history of the concept of shared decision-making. The term was first coined by the late Bob Veitch in 1972, though it really didn't start to enter common parlance until the 1982 President's Commission for the Study of Ethical Problems in Medicine, Biomedical, and Behavioral Research did a big report on informed consent and really came out. That's important context to remember because really this was a reaction to worries about physician paternalism, particularly for Bob's paper in 72. It was really against the backdrop of worries of physician paternalism and the efforts of patients, and it was part of the patient empowerment movement of taking power away from physicians and giving it into patients. It was also partly a recognition that informed consent, which was the way in which people that had traditionally thought of that and had problems with actual implementation. So that's really shared decision making was meant to do this. If you look at medicine is very interesting in that if you go back to the Hippocratic tradition and if you go back all the way to Hippocrates, concepts like confidentiality, taking care of the patient, making sure their interests are respected, conflicts of interest are all covered in the Hippocratic tradition. Nothing about informed consent. Informed consent, the idea of patients having a role, really not a major view in medicine for most of the 20th century. And it came not from internal to medicine, but external to it. Informed consent and the importance of patients having a role in self-determination when it comes to medical decision-making was not something that the medical community said, this is something we should do. It's something that was imposed on medicine as part of political movements by patient power things and mostly by the courts. Going back to 1905 and the Moore v. Williams case, which said for surgery, patients have a right to consent before surgeons can do things to them. The very famous case that Stanford was sued over, Salgo v. Stanford, 1957, which said consent is meaningless unless the patient has some level of understanding and established informed consent. Canterbury v. Spence, which said that the standard of disclosure shouldn't be set by physicians, but by patients or reasonable patients. The same thing happened in research. The Helsinki Declaration in the 60s and then the Belmont Report in the 70s, because up until that point, traditionally, physicians in research also did not get consent and just did what they thought was best on behalf of patients. And then finally, in 1990, to the Patient Self-Determination Act. So I'm going to start by saying some conceptual problems, I think. There's been a lot of literature about problems of implementation of shared decision making, and I'm going to talk a little bit about those later. But I want to start with the problems with the concept. It's a terrible term in a lot of ways, right? Informed consent, not shared decision making. Consent is a legal requirement and an ethical requirement that allows clinician researchers to do things to patients that otherwise would be battery or assault. Right? So the legal authority for these authorizations resides in the patient or the surrogate decision maker, not clinicians. And again, that was imposed on medicine by society and by patients and by the courts. Therefore, when you think ultimately in shared decision making, that makes it sound like there's this partnership and equal partners. For most of the things that we're talking about where it's actual consent, this is not a shared partnership. This is ultimately, if it's about informed consent, that patients have the sole authority to authorize procedures from at least a legal perspective. And really, instead of calling this shared decision-making, it should be called assisted decision-making, because the physicians in most models of shared decision-making are there to help the patients have better understanding so that they can make informed decisions. But the authority is not shared, it resides in the patient. It's important to note the context of all this was initially most of this movement around informed consent was grounded in patients' right to refuse unwanted interventions. That's really the main area. And then to a lesser extent, a secondary area, which are the things that Doug and Randy and everybody were talking about, were these decisions where there are very complex decisions, where the burden benefit ratio is not clear, or where there are multiple options that are all within the range of reasonable options, and they're different enough that they're going to be patient preference sensitive. And that's a fairly limited domain. But it's also worth noting that because this is in these very narrow domains of either refusals or these domains where patient sensitive decision making makes sense, there's lots of domains where the decision making is also not shared, but it's because physicians have the authority to make those decisions, right? So physicians have domains of authority through a number of concepts for allowing unshared decisions in which physicians have the authority to make decisions. So concepts of non-candidacy. If a surgeon decides a patient is not a candidate, that is not a the shared decision that you're engaging in, you just decided they're not a candidate for surgery. Sometimes you tell them that, sometimes you don't even bring it up to them. In oncology cases, there may be things where the physicians among themselves are discussing options, but they often don't talk to the patients about what those things they discussed even were, because they've already made a decision that this patient is, quote unquote, not a candidate. And so candidacy is a way of making unshared decisions. There's also medically ineffective care, futile or non-beneficial care. And of course, there are a million institutional factors that also limit patient autonomy to make decisions. Formularies, what's covered by insurance, et cetera, really lead to unshared decisions in which patients really have no choices about a lot of things. So those are conceptual problems with it. Let's also ask the question whether shared decision-making really works. In this paper, Peter Ubel and a bunch of other colleagues, Karen Schur, did a really interesting study where they were looking at some of the factors that govern decision-making. This was a nice study because what they did was first they asked patients about their views about what their preferences were, aided by a decision aid. So what is it that their preferences were? They elicited those things. They recorded the conversations with the clinicians, and then they looked at the factors that governed the actual decision of what happened. And what they found was that the patients' articulated preferences for what they wanted were completely statistically insignificant in terms of the decisions that wound up being made. What major factors were that drove the decisions were urologist recommendations, and especially the biological factors behind them, Gleason scores and age. Those were the major determinants of what happened, not patient preferences. And in the recordings of their conversations, they found that aspects of things that mattered to patients, in this case, like preferences about sex and other kinds of things, were very rarely discussed or brought up at all in the course of conversations. And what's interesting is there's a lot of evidence that decision aids can be beneficial and can help with understanding patient preferences better and prepare them better. But ultimately, once you get to that stage of the actual patient encounter, that's really where things kind of go wrong in terms of, or maybe they go right, but it's where things diverge from really patient preferences really driving the decision-making and instead become physician-centered. There's lots of other studies of communication between patients and physicians. This study by Doug White and Randy Curtis, this is an old study. They recorded conversations and had like some of the basic elements of shared decision-making that you want to make sure were covered. They found that only 1 out of 51 decisions met all 10 criteria for shared decision-making. In a study that we did of decision-making for parents with critically ill children in the PICU and the CVICU, we found that actually none of the cases had all of the elements of shared decision-making. We only had 19 where decisions were made of the 30 conversations recorded. So maybe if we got to 50, maybe 1 would have been good. But anyway, but in any case, it's rare that actually most of the things that you really need. And you can see that even things like what the risks are, what the benefits, what the alternatives are often rarely discussed with the parents of these sick children. Moreover, there's other studies showing similar things. Physicians often mislead patients and say misleading things. In one of our studies of treatability, I'm not going to go into details, but I'll talk about treatability a little bit later. One of our interesting conversations with oncologists was the way in which they use words that they know the patients don't really understand, because it helps patients make what they think is the right decision. And if the patients aren't sort of nudged in the right direction, even by misleading them, they're worried that they're not going to do what they think they ought to do. Anyway, and this is a study showing that over half of physicians are self-reporting that they often, rarely, or sometimes describe patients' prognosis in a more positive manner than was warranted. There's another study about how physicians discuss critical preferences. And this is, again, 71 conferences recorded near end of life for incapacitated patients. No discussion of values or previous preferences. That is, neither was discussed in 30% of the cases. 33% of the time, one or the other, but not both. Only a little over a third of the time were the patient's preferences and values actually discussed in the course of these conversations. And on average, 3.8% of words spoken pertain to patients' preferences or values. Okay, so on the whole, to summarize, most of the time, communication is really not very good, not very strong, often misleading, and it leads to the fact that the patient preferences often are not really playing a big role. But I'm actually going to say something else, which is even if you try really, really, really hard to get it right, it's harder than you think to get it right. And that's really a subject of we have a lab, a national collaboratory now. We have a lab here at Stanford that studies patient-physician communication, and we work collaboratively through this large collaborative network. Includes a guy named Bob Arnold, who's a palliative care physician at Pittsburgh, and Gretchen Schwarze, who's a surgeon at Wisconsin, and some other folks at Wisconsin and Harvard. And there's a whole bunch of us who study communication using concepts of really pragmatics, and to move away from what typically is used, where you look at the literal meaning of the words, and instead focus on what we do with the words and what actually gets conveyed, rather than what the literal meaning of the words that we use, because that's really what matters. I'm sorry, do you know what time it is?
It's 7:52.
Okay, so I asked you a question and you didn't answer my question. I asked you if you know what time it is. You ignored the literal meaning of my words, the question about the state of your temporal knowledge, to instead tell me what time it is. Because that's really the point. You ignored the literal meaning of my words, which is a question, to instead make an inference about what my intention is between for why I would use those words in this kind of particular context, to make an inference that what I was actually doing was making a request for you to tell me the time. And in different contexts, you can use those same words with the same meaning to convey totally different things and perform different speech acts. My wife's running late and I go, do you know what time it is? I'm actually complaining. So you can do different speech acts with the same words. So we've been using this framework to do a whole bunch of different studies, hedge language, other things. Our first big one was about studies of treatability statements and serious illness, and what it means to say that things are treatable. What we found were there were two very different concepts of what it means to be treatable. One was a good news concept. When a physician tells a patient that your condition is treatable or there are treatments for your condition, they're conveying good news, versus an action-oriented approach, which is just saying there's stuff for me to do, and it may or may not have very much prognostic significance. And as you'd expect, patients almost all thought that it meant good news, and physicians almost always thought it meant that there's something for me to do. It was also very interesting to see differences between different specialties. The oncologists were particularly interesting because for them, all the ones we interviewed said, when you say treatable, that means incurable. You would never say treatable if it's curable. And so treatable almost means disease-directed therapy for an incurable disease, which almost no patient ever understands it to mean, unless they're very experienced as oncology patients. So anyway, so this is basically the problem. While decision aids can be helpful, communication is ultimately at the core of successful shared decision-making and essential to meeting the ideal vision of actual autonomous authorization. But actual communication is often poor. And moreover, even if you're doing a really good job, it's harder than you think it is. And in fact, you have to actually study what the conversational implicatures are, and how people tend to interpret things, to really even understand how using common language and simple language and saying things plainly can really go awry. Therefore, shared decision-making is actually rarely achieved and really hard. And I don't have time to go into this, but it really raises for me the question about really whether or not shared decision-making really and informed consent have anything at all to do with what we traditionally think it's for, which is that autonomous authorization and the authority over making decisions, or whether we instead need a linguistic anthropological lens to see what these things are, which are certain kinds of rituals that play certain kinds of roles in the process of demonstrating respect for patients. Neil Dickert's done a lot of this in the research context, but we really need to maybe rethink what this is all about, because whatever it is, what we know really well, especially people who study how much understanding there is at the end of informed consent, which is abysmal, it's probably not really about that. Okay, thanks very much.
This is fantastic. Does anyone have any questions for their panel?
I have a question. So, hi, I'm Jake. I'm one of the head and neck surgeons, but with oncology. But with the question that I always dislike is when patients ask, "Oh, what would you do if this for you, or this for your mother or your father?" Because I mean, honestly, it's like I'm having to displace my own values, which I probably don't even know what my values are in that scenario because I've never been in that scenario. But how would you recommend navigating that question?
Well, I have views about that. First of all, I think in a way, navigating these conversations, you're between the Scylla of paternalism and the charybdis of abandonment, right? So it's an attempt to try and let the patients have autonomy, often leads to abandonment because you're not really making recommendations. So I think if you have so Gretchen Schwartz's got some interesting work she's been doing now, where she says like there's sort of 3 ways of thinking about this, and the start of every conversation should be putting your cards on the table. I don't think this is work that I don't think she's quite published yet, but will be coming out soon for those of you like me who are really fans of Gretchen's work. Anyway, so the first cases are ones where they should probably do this, and if they don't, probably they're not really understanding, and then you should tell them that. You definitely would want this. You should definitely do this. And then there are other cases where you're an 83-year-old guy. You've got a whole range of health problems. This is probably not going to go really well, and you need to be pushing them the other direction. And you should put your cards on the table and say, I wouldn't do this. I would recommend against this if this was my family member, and I think this is a really bad idea. And then what's tricky is the in-betweens, which is, I think, a smaller domain than people realize. But that smaller domain where it really is like, this could go either way. And then that's when you start to be like, this can go either way. And now we're going to really dig in and we're going to start to try and figure out preferences. But the reason why that's important is you do want to know something about their values because they may be odd in different ways around those extremes. But once you take that off the table, there really shouldn't be a lot of worry about those 2 cases where it's like you should either do this or you don't. All too often, we do things that we think is a bad idea in the name of shared decision making. Well, there's a chance or whatever, and it's like probably given who they are and stage of their life, this was a bad idea. It shouldn't have been offered in the first place. So anyway, and the same way, it's like, of course you should have the surgery. Anyway, so, and in that middle case, that's when you start down the pathway of true shared decision making and start to work with them. And there's Gretchen's got a whole set of tools in the surgical context of things you should be doing to work through their values and help them make those decisions and navigate them. But use those tools in the cases where it's appropriate, not in the cases where, yeah, you should of course tell them, God, I would never want my dad to have surgery. If he was in your health situation, do this, no way I would want to do that. Anyway.
I would say a couple of things is I would ask them a couple of questions. Like, so tell me a little bit about like why you're asking me what you're asking. Like, what are the things that are on your mind? What are the things that are most fearful to you? And I try to bring it back as much as I can to the why they're asking the question that they're asking. And it usually, once you've unpeeled the onion enough, you start to realize they're really afraid of X or they're really hoping for Y. And then you can use that information to say, well, based on the fact that you're afraid of X, you're hoping for Y, my recommendation would be Z, right? But I think if you don't unpeel the onion completely to really, like sometimes people say, Doc, how much time do I have? And I'll be like, so tell me the kinds of information that would help you to put that into a framework that works for you. Well, my daughter's wedding's in 2 weeks, or I have a life insurance policy that's X, right? So then I can take the data that I have and reframe it into a way that makes sense to them, right? And then it's more appropriate rather than my bias, which could be, well, the range. We used to be taught the range from weeks to months, months to years, which were quite accurate too. But
I think Dr. Capasso had a question online.
I think, well, thank you. I think a lot of it was answered already by the past 2, but just emphasizing then in a different frame. I think as otolaryngologists, non-head and neck cancer, we deal with a lot of conditions, chronic conditions, who patients are aiming for quality of life improvement through surgery. And a lot of times they already read a lot, let's say for you need to breathe your nose or you need to sleep well, and they come through surgery as the solution for that issue. How do we engage another healthcare providers to actually convey a message that surgery may not be the best path for this person, may need to lose weight, may need to stop drinking before going to bed, not necessarily surgery. I mean, we see that over and over again in the clinic.
Yeah, actually, somebody brought up non-candidacy, and the surgeon's deciding when I'm not going to operate and I'm not going to offer this. That's, I think, one of the most difficult conversations that I have or trying to engage with.
I do believe there's a domain. I mean, so as I said, the patient, the notion of autonomy ultimately was really grounded in that movement and the right to refuse unwanted treatment. It's not grounded in the right to demand anything when it violates medical professional standards. So there has to be space for clinicians to exercise judgment about things that they're just not willing to do. So, there's a little small fight in the literature. Norm Risk, who used to be our chief medical officer, and I published a piece on one side, Doug White and a philosopher on the other side. They think there are circumstances where it makes sense to try and force surgeons to do life-saving procedures that they think are not indicated or that might potentially be life-saving indicated. I'm on the opposite side of things. I mean, it bothers me that of all the different groups, intensivists are the one group who don't have the luxury of saying, I'm sorry, but this is not going to go well. So right, we have futility as a mechanism or workaround, but it's funny that intensivists don't have the ability to say, I'm sorry, but you're never going to leave the ICU, and this is a one-way trip, and so you're just not a candidate for the ICU. So it's kind of interesting that we give that authority to some and not others. It's also that if you look at the language used in exchanges, that when you record conversations, surgeons and other kinds of interventionists use the language of gift. So when you talk about what you're doing with respect to surgery, you're offering surgery, you're offering a procedure. It's a very gifted language, which means, of course, it's up to you as clinicians to make the decision about whether you're going to offer this gift. Whereas if you look at the language that intensivists use, it's much more of an almost economic exchange thing in the way in which they use these descriptions and talk about these things. I'm sorry, I really find it interesting, the language that clinicians use, and I like looking at these recorded conversations to see what they're, anyway, sorry.
I know we're near the end of time, but I just wanted to follow up on something we were discussing before this panel, where I think it might be beneficial to our trainees, because we talked about it a lot, where they are often, at 2 a.m., someone comes in with an acute airway, and they don't have a lot of information, but they're almost at that intersection where if we proceed with the procedure and, give them an urgent airway, potentially they could be in the ICU and pass away in the ICU, but we don't have that information yet. We're sort of unlike an A or B situation, we're in an I situation where there's a lot of uncertainty. We don't know exactly what's causing it. We don't know their values, their family support, if they can even go home potentially and manage the trach at home. And so, and then often this is a second-year resident on call trying to manage this discussion at that time. Do you have any suggestions or recommendations?
Probably the wrong place to be having those kind of conversations in the right context. So usually in those cases, you save them and then we have those conversations later. Our ethics service, we help with that palliative care. We all come in afterwards and have those conversations later. But to be honest, a lot of times you've already failed when you've gotten to that point, because usually the crash is not coming out of nowhere, and there were opportunities for better discussions about their preferences beforehand, and those never took place.
At the same time, I mean, it really does speak to how much paternalism is embedded with our system. And certainly that kind of scenario plays out all the time, including with patients who have had that discussion and decided that they did not want to be intubated. They are intubated anyway.
Yeah.
In the NICU, I mean, I think we practice with we will do things in the middle of the night, even if they haven't been discussed, and then discuss them later. We don't have the luxury of always having the decision maker in the room at the time. We have I would say the majority of the children in the NICU don't have a family member present 24/7. So we are often faced with having to do emergent things without a lot of kind of knowledge of the situation, of what their decision might be in the moment.
And in an emergency, there's no informed consent required.
To David's point, I think bring that urgency early. We have that urgency in the ICU when people are crashing and burning. We don't always have that urgency in the outpatient setting, right? And we really need to bring that urgency early. Those conversations need to be happening with the same import with the people that they trust, which is the doctor they've seen 8 times, or the nurse that they know really well. And if we don't do that often enough, Jennifer Temmel says all the time, prognostic awareness is a process. It's not done in 1 conversation, 2 conversations, or 3 conversations. It's done in 15 conversations over time. Usually 6 months later, the patient will say, so you're telling me I'm not curable? I'm like, yes, but it literally took that many conversations for someone to get there, right? So we are very complicated as people, and we have hope, and we want to believe certain things. So it takes a lot to get that to be changed. So bring that urgency up front, and I think it will make a huge difference.
But can I make an appeal for studying these things though, because it's so easy to get wrong, right? So even when they use the same words, we've been studying hedge language, and so one of the things, I had this case once where they were trying to introduce to a guy that his dad might be dying, and maybe it was time to think about palliative care, and so the person had a great conversation. Said, "Look, I'm worried that your dad may not get better." I'm not saying he's going to die tomorrow, but I'm worried that there's a chance that he's not going to make it, and he's really, really sick. And so we wanted to bring up the idea of palliative care, and the son said, "So I hear you saying Dad's really sick, and he may not survive this. So we should just keep going and doing what we're doing right now." And they think they're on the same page now, and the teach back worked perfectly. But because I'd been thinking about hedge language, I said, when you said he might not get better, did you mean it's like a coin flip, whether he's going to get better or not? Did you mean it's a roll of the dice and there's a 1 in 6 chance? Or do you mean this might not be the winning lottery ticket and he might for getting better? And she said, this might not be the winning lottery ticket. And the son goes, "Oh, I thought you were giving me good news.
No.
Dad is really sick and he might not get better." But thought that, anyway, they just completely misfired. And it's really hard to know if you aren't thinking about and haven't studied how these different words are interpreted differently by different patients, how it can go awry, even in cases where teach back seems to be working. So anyway, so appeal for more research in this area.